Roux-en-Y, this is probably the most common, it's been around for a long time, and is not, it's still commonly done, probably not the most common anymore, but it's been around. Al Roker, if you watch NBC, this is what he underwent, his Roux-en-Y. So you can see what they do is they I always have to back up and look at it. So I know the fundus, they create a gastric pouch, and they are going to connect the small intestines to that. So this is where the restrictive part of it comes, because you can only eat so much. And then they have bypassed a lot of the absorptive capacity by cutting out this section. So what they do is they allow the gallbladder and the pancreas to still contribute digestive enzymes. The exocrine part is still active and then enters in here at the small intestines, but the rest. So this becomes the alimentary part, and there is a malabsorption because there is a small amount of bowel that is removed as well. Okay, so with the Roux-en-Y, it's restrictive and malabsorptive. You'll see under the weight loss is about 70% in 2 years. Okay, so if you weighed 400 pounds, you're now going to weigh about 120 to 150 at the most. Not all patients get that far. Let's see, the sleeve gastrectomy is another common one, popular, you can say that. Okay, so they, So it's, they've cut out most of the antral part of the stomach, so they've reduced its capacity. So it's a restrictive, they don't remove any of the small bowel. So you can certainly increase that again. It's a problem with all of these is that eventually these pouches will stretch if overfed. In 2016 is the most commonly performed bariatric procedure. Its weight loss is 60% at 2 years, so very similar to the Roux-en-Y with maybe not as many of the problems with malabsorption. Here is the adjustable gastric band, so they go in and put a band and cause a restricted pouch. This port is under the skin and can be accessed by a needle, and so to change the force on that or the constricted nature of it, they can add saline to it and adjust it. The banding used to be very popular. It's fallen in its popularity because the weight loss is very slow. It's about a pound or so a week, so it's very comparable to going on a diet, and it takes a long period of time. So this one has fallen more out of favor. It lists it down as expected as 50 to 60%, which puts it up there pretty close to the other two. But a lot of recidivism, high rate of people abandoning it. So it's a reversible. So that shows you them accessing that port under the skin. And the last one is the biliopancreatic diversion with duodenal switch. I don't even know if I can work you through all this. So they do cut out part of the stomach. They reroute, and the duodenum, or part of the intestines, and I'm not sure if that's the ileum. I'm not going to pretend. This one, though, is really, in diabetes, it has had tremendous impact, and they think that some of this is their GLP concentrations go way up, and that the hormonal effects of this surgery are thought to be highly responsible for the type 2 diabetes going away. In fact, usually the diabetes will respond before, or the blood sugars will normalize before the weight loss is significant. So that is the fourth procedure. And you see under expected weight loss 70 to 80%. So that means they're 20% of what they used to be. So these would be in fairly large people. So I'm not going to test you over those, I think, because I'm not well versed in them. I can describe them to you. I understand when people have them. I think you need to know which are restrictive, which cause malabsorption, their expected weight loss. And read through the description so you're familiar. If patients come in and tell you this is what they had, you would at least recognize it. Laparoscopy, I told you, is the preferred. Patients stay in the hospital longer or shorter. They recover faster. So preferred if you can do it. So on to page 6. So hospital duration is pretty short. If they have a laparoscopy, they may be out the next day. If they have Roux-en-Y, they may be in 2 or 3 days. If they had it under laparoscopy, if they have to open them up, then that is longer until the gut starts to the action and they can take a liquid diet and they can get up and move around. So in looking at what they need right after the hospital stay, is hydration is really important. They get dehydrated very fast. They have experienced a lot of nausea, and this is the most common reason for readmission. So a lot of time is spent on educating them about staying hydrated, taking in a normal fluid. They can't hold a lot because their stomachs now are restricted to just a few mils, so they can't take a lot. I have worked with these folks as a pharmacist after surgery in working with them, how do you get all the pills down? And there's a lot of follow-up. When we get to the long-term follow-up, there is a lot of downward titration that has to take place once they've had the surgery. Their blood pressure usually will start to normalize, their blood sugars. If they have heart failure, sometimes they can come off some of those medicines. So you've got tablets that take up space. So we usually have to crush those or prepare them in liquids for them to take. They can't take controlled release products. They can't take anything. They have to open up like a capsule. So there's lots of working with them on how do you get the medicines down. I can't give them all their medicines in the morning because it exceeds their gastric ability. So there's lots of work with them from that standpoint of just how to get the medicines down. Nutrition and supplementation, all of them will need a multivitamin. If they've had a Roux-en-Y and they can't absorb and they're malabsorptive, then you have to do supplements of A, D, E, and K because their fat-soluble vitamin uptake is reduced. Diet, they start off with clear liquids. They advance based on the type of surgery they've had. Will more dictate this. So start off with clear liquids, advancing to full liquids or a pureed diet, like baby food consistency, then to a soft diet, then to a regular diet. So you can see it takes multiple weeks for them to get to the diet that is going to sustain them. Pain medications are important. Here they use opioids. More often, they stay away from non-steroidals because of the propensity to develop ulcers. The one exception would be aspirin if they have had coronary stents, if they have had an MI, and I don't know if they'd be a surgical candidate, but if they have a just reason for the aspirin that where the benefit outweighs them coming off of it, like a post-stroke, then they would continue those. So the aspirin can be continued with an indication. Non-steroidals are not used for pain. They use opioids for a limited period of time. If they have to be on the aspirin or a prednisone for some reason, then using a proton pump inhibitor to decrease the risk of ulcers is recommended. Usually these people are on some types of blood thinner. So if they were on warfarin before and they're going to continue on, then that requires almost daily INR or PT checks for a while until you get them stabilized. Because the food, now that most of their vitamin K is gone, and they don't absorb the vitamin K as well, so this requires a lot of readjustment. We had a couple of people in our Pimminent clinic that had Roux-en-Ys, and they had hard times getting vitamins with A, D, E, and K in it in the amount needed. They used to get their sources out of Canada, and that dried up at one point, and so we had to have them come in again frequently to get their INRs checked because of that change. Educating patients on warning signs. So this is when they should seek medical attention. This would be common for a lot of post-surgical patients. So spiking a temperature, severe abdominal pain, appearance of an infection or inflammation around the incisions, draining, vomiting that they cannot control, chest pain, shortness of breath, worried about them throwing a clot, severe pain, warmth or redness in the calf. And then these patients are frequently followed up and usually seen by a team or by multiple physicians over for the rest of their life. So you will find them, if you're in primary care, they will show up in your clinic. So there may be things that you will be following them for that will fall into more of this long-term management. Questions or comments about that initial post-surgery or when they first get home? Okay, let's look at long-term management. So blood pressure, I've never seen a person who was undergoing the surgery that didn't have hypertension. Blood pressure is one of the things that will usually resolve or get much better. So titrating them off medications is important. So monitoring that and downward titration of drugs would be important. Blood sugar. All the diabetics I saw post-surgery went off all their meds. I saw people on multiple insulins and multiple oral agents together that blood sugars returned to normal. So in some of them it was very quick, and in some of them we just did a downward titration. Usually for the insulin patients, I just took them off the insulin. And I would then give them schedules of how to use them as supplemental. Or we put them on 5 units of Lantus, very low amount of basal, and then have them use a bolus only when they had spikes. But usually very good resolution. And with tremendous weight loss, almost all of them came off all medicines. So monitoring their blood sugar at home would be really important, making sure they understand the importance of monitoring. And I think by that time, most of them do. Lipids, often their diet is going to be so radical and so low in fat that most of them will be able to normalize their lipids. So their LDL will go usually to normal, total cholesterol, triglycerides way down, and HDL may be the problem because you may not be getting in enough fats to keep that HDL up. So again, if they were on statins or drugs to lower their cholesterol, working with them to get them off of that as well. Sleep apnea, as they lose weight, they may need to be reassessed for either settings or the need for continual CPAP. GERD sometimes gets better, sometimes it gets worse, depends on the type of surgery they have. Sometimes GERD will start after they have the surgery and they never had it before. So that's one that doesn't necessarily respond, so taking them off if it does respond, but always looking for new onset. Cholelithiasis is a common thing, gallbladder gallstones. And this occurs with anybody who loses weight rapidly. So people that go on these liquid diets and stay on them for a long period of time, several weeks, the cholesterol and estrogens will precipitate gallstones pretty quickly. So not an uncommon thing in rapid weight loss. So because of that, they start them on ursodiol twice a day to prevent the gallstone formation. Not a drug you see very often, but is pretty effective. Dumping syndrome, so the patients often don't have any, they'll have fecal incontinence. If you go and read about Al Roker, and he tells a story about this happening to him when he went to visit the White House, that he actually had, he went in his underwear, and it's a normal, not a normal, but it's one of those side effects of the surgery. They're higher risk for kidney stones, monitor for depression. So this is part of the workup before, is treating them. Sometimes depression starts, is a new onset after surgery. Suicide rate goes up in this population. We'll talk about that in just a little bit. Looking at calcium, iron, B12. So if you cut out a lot of the stomach, how's the stomach contribute to B12? Intrinsic factors. So if you remove a lot of the stomach, or you then put them on a proton pump inhibitor for other reasons, then they may have developed a B12 deficiency. Folate, thyroid. So following those on a regular basis. Long-term diets, their diet is pretty much consistent with the macronutrient diet that we recommend for everybody. So predominantly carbs, and then fats and proteins. A little bit higher on the protein range is a little bit higher. So 0.8 grams per kilo is usually for a normal adult. They have them here from 0.8 to 1.2. Carbs about 50% of their calorie intake. Food aversions are common to occur during this time, particularly because they get nauseated, sick to their stomach often. And food intolerances can also occur that they didn't have before. So some of the changes that might happen. Questions about those? So a lot of follow-up. That's why I think that some of it would fall in your domain long-term as you see them. I've seen several long enough that I saw them regain enough weight that we had to put them back on medicine. So the lady that I told you that was 440 pounds, it went to 150. When she gained back up to 250, then she had to go back on medicines to control her blood sugar. She went from an A1C of probably in the high 5s at the lowest to back into about the 7.5 range. But she was very meticulous about checking her blood sugar, and she elected to go back on insulin. She felt like it controlled her better than going on oral agents, and the oral agents took up too much space. Metformin's huge, so trying to get that down, we used a liquid instead. She elected to go with insulin. Let's see, medical outcomes. So weight loss, that's the reason why they do it, and it's usually fairly significant. So if you look down there, average is about 10 to 15 pounds per month. Depends, again, on the surgery that they've had. Weight loss average at 6 months is 60 to 80 pounds. Then the weight loss slows down. They tend to lose about 5 to 7 per month and lose anywhere from 100 to 120 is average, but it could be quite a bit more. The adjustable gastric band, we talked about a pound per week, so that's why a lot of people abandon it, because it's so slow. Diabetes mellitus, looking at the evidence here. Again, often their blood sugars are going to normalize preceding the weight loss, so that's why you don't wait for them to lose a lot of weight. And they're going to be seen frequently, so reporting low blood sugars, reporting blood sugars, having them even fax them in are important. GLP-1 is what has been implicated as the reason for that initial success in blood sugars. And we know they're impaired in type 2, so it comes back to normal, and that's probably the reason why their blood sugars get better quickly. Study outcome, that first one is impressive. So uncontrolled type 2s that underwent a Roux-en-Y were significantly more likely to achieve an A1C of less than 6%. So what's the average or the goal for a general population of diabetics? Less than 7. Treatment goal is less than 7, not diagnostic goal, less than 7. So these folks were able to get to less than 6%, which is close to normal, because so normal is what? Less than 5.7 or less. Remission rate of diabetes at 2 years compared to those who were medically managed was 75 to 90% remission. That's amazing. Rates of partial or complete remission were significantly higher with bariatric surgery compared to other interventions. And that last one's really interesting because these were patients who had documented neuropathy. And they found improvement or normalization of their score after the surgery. Now, we usually tend to think that that is a permanent change. If you have neuropathic damage, that it cannot recover. But in these patients, their scores returned to normal or near normal. Hypertension, remission with Roux-en-Y, 79%, with blood pressure, 68% with the sleeve, 44% with the adjustable band. That's impressive. That's why when I deal with these folks, it's always about food. It's always about food. They're controlled. It's always related to what they're eating, usually, and how active they are. With lipids, dyslipidemia, you can see triglycerides decreased by 63%. Very good. LDLs by 31%. That's equivalent to drug effect. VLDL, which is your precursor to your triglycerides, is 74%. HDL increased by 39%. 82% of the people who were on lipid-lowering drugs didn't need them afterwards. That's probably my biggest message to you, is that drug therapy changes a lot. For sleep apnea, it's variable. So some people get better, some people don't, and are required to continue their CPAPs. With the GERD, again, some people get better, some people have new onset. But overall, the rate of GERD medicine to control GERDs decreases. Pain and physical function, here it's variable. Significant improvement in body, hip, and knee pain. But between 1 and 3 years, the improvements were in knee and hip, but declined in body pain and physical function, sorry. Physician function may have declined too, but it wasn't related to their surgery. PCOS, so about 30 to 70% of these women, menstrual cycles were restored in about 3 to 4 months, so it's important to talk to them about, about birth control. Hirsutism and elevated androgen levels normalized by about 8 months. Insulin resistance went down, and an increased ability to conceive at the 2-year mark. In women, about 70% of them were able to conceive that were infertile prior to. So normally, in a group of women who are in their reproductive years, in 1 year without birth control, we expect how many to become pregnant?
15.
How many? What percent? 85%. So this is very close. I mean, they're achieving 70%, so very near the general population. Urinary incontinence improves in both men and women. Some of them will return to normal, some of them they get an improvement. Non-alcoholic fatty liver disease. Why do we worry about this?
Lead to cirrhosis.
Leads to cirrhosis, the more severe form is NASH, which can lead to cirrhosis, and what else did you say?
I just said hepatitis.
Hepatitis. So this is really important. Very common comorbid disease with diabetes. So the majority of patients will improve. Some of them go to normal. Some of them have significant improvement. Last page, psychosocial impact. So it is usually associated with an improvement in depression. Compared to before surgery, severity of depression was reduced by 8 to 74%, so different studies. Eating disorders usually decrease after bariatric surgery. Quality of life and body image, higher quality of life, more satisfaction with body image. But in terms of impairment, approximately a 50% increase in the incidence of suicide after bariatric surgery. Self-harm emergencies also went up, so those just need to be a higher surveillance of those, and knowledge that that may be a new onset. Questions? Yes, go ahead.
I have a question related to the peripheral neuropathy resolving. Just in your diabetic claims, did you ever see that happen?
Never. Never. Now, if they've got symptoms due to high blood sugars that have been sustained, if you can get the blood sugars down, then yes, they will improve. But if they stay elevated over long periods of time and that nerve eventually becomes non-functional, you don't get function back. The nerve just, the ability to transmit impulses goes away. You lose myelin and they just don't work anymore. So they don't have the pain anymore, but they also have no sensation. Okay. Okay, prescribed diets. We won't get through all of these, but we'll start them.